everyone. Welcome. Thanks for taking time out of your busy schedule to join us in the Roundtable today. And that's all the faculty here as well as the participants. So we want to say that this is a project of the Asian Health Institute in collaboration with 3 other institutions, and that's the University of Washington, Chinese Hospital, and the Kaiser Foundation, Kaiser Permanente Hospital in San Francisco. And so we annually have a symposium, but this year, because of the COVID, we changed it to this webinar just to kind of continue the tradition, so to speak. We want to, at this time, dedicate this roundtable to all the healthcare workers who has been working so hard through the COVID, putting their life on the line, trying to save patients and helping the whole community, trying to take control of the situation a little better. So this roundtable is dedicated to all the healthcare workers, including many of our colleagues at UCSF, University of Washington, as well as Chinese Hospital, Kaiser Permanente, and all others. Dr. Peter Chin Hung is our Vice Dean for the UC campuses. His job is, shouldn't be telling about your job. you know about your job.
Not to worry. Spend time introducing me, Diana.
But his job was to make sure that all the UC campuses in the medical schools, that the curriculum is similar. Is that right? That's your main taking? Yeah. So he's a very important person, and then he's within UCSF, and he's a professor within the Department of Infectious Disease. So we're just so very lucky to have Dr. Peter Chin Hung always helping us in this COVID stuff, because he is definitely the expert in the area himself. So these are our panelists today, and with Dr. Peter Chin Hung as our moderator, and he's going to introduce all of them, and they're from different specialties, including internal medicine, and we also have faculty from University of Washington, as well as Chinese Hospital and Kaiser. For today, we have 2 parts. Part 1 is for about an hour, and we have different speakers talking on different topics, as you can see on the agenda. And again, Dr. Peter Chin Hung will be leading through that part. And then part 2 are the Q&A session. And some of the Q&As we kind of prepare for the different specialties. And then some of the Q&As we let participants fit in. I just want to share this picture with this slide with you. It is a slide that was collectively done by the California Healthcare Foundation and other organizations. And so what it shows are how COVID has affected the healthcare system. We know that it affects the community in terms of how our life has been impacted, our jobs has been impacted. But as a whole, very few people talk about the healthcare industry, how it impacts us. And so if you can see on the screen, you will see that, most of the areas are impacted: outpatients, inpatients, ED, and you can have drops as high as 90% that the business has been stalled. So with that, I'm going to turn over to Dr. Peter Chin Hung and let him introduce the rest of the speakers for the day.
Great. Thanks, Diana, and welcome to everybody to coming to this really engaging webinar on COVID-19 with a focus on Asian Americans, often an underlooked population, I think, when we talk about COVID-19 in the US. So without further ado, I'd like to introduce our first speaker, Dr. Janet Chu, who's really going to start by talking about the burden of disease of COVID-19 amongst Asian Americans and whether or not there are any disparities that are invisible or visible. Dr. Chu is based at UCSF in internal medicine, and somebody I've known for quite a long time, and it's been great to see her develop over the years.
So thank you so much, Dr. Chin Hung, for the introduction. Good afternoon, and thank you all for having me here today. Again, my name is Janet Chu. I am a fellow in general internal medicine here at UCSF, and I'm going to be spending the next few minutes setting the stage and context for what I know will be a very rich discussion over the next 2 hours. I have no disclosures to report. As you all know, the WHO declared the novel coronavirus disease COVID-19 as a pandemic on March 11th, 2020. And most of you are probably familiar with this map created by the Johns Hopkins University. I know I was checking this very frequently during the beginning of the pandemic anyways. And as you can see, worldwide, over 31 million people have been infected with COVID-19, and there have been almost 1 million deaths. The US currently leads the world in the number of COVID cases and deaths, having recently surpassed 200,000 deaths here in the US over the last few days. Some staggering numbers. But we know that COVID-19 hasn't affected all communities equally. Communities of color have been disproportionately impacted by the pandemic. And this graphic, which was released by the CDC in mid-August, highlights some of the racial and ethnic disparities in cases, hospitalizations, and deaths, particularly among Black, Latinx, and American Indian Alaska Natives, with Asians having slightly more cases and hospitalizations compared to non-Hispanic whites. But if you delve deeper into the racial ethnic data reported by the CDC, you see that race ethnicity data is missing for almost 50% of cases. That's 2.5 million people and 20% of deaths. This lack of accurate and complete racial ethnic data really raises concern about unknown COVID-19 disparities, particularly among Asians and Native Hawaiian Pacific Islanders. Even though the Office of Management and Budget requires that agencies that receive federal funding report Asians as a separate category from Native Hawaiian and Pacific Islanders, some states continue to categorize Asian Americans and Pacific Islanders as one category. Others aggregate Asians, Native Hawaiian Pacific Islanders, and American Indian and Alaska Native under one category of quote-unquote other. So this really leaves disparities in these communities really unknown, inaccurate, and unidentified. This is just a few examples of a couple of states from COVIDtracking.com that, for example, Arizona reports Asian as a pan-racial category that includes Asian Pacific Islander and Native Hawaiian, and Florida that categorizes Asians under just other. So I want to present some data on a project I worked with Dr. Janice So here at UCSF, Elena Ong in Los Angeles, and Dr. Nanette Ponce out of UCLA. And the data is from the National Center of Health Statistics, which provides weekly updated data on COVID deaths distributed by age and race ethnicity at the national and state level. And at the time that we first did our analysis, probably back in May, June, this is one of the few publicly available data sets that really disaggregates data for Asians and Native Hawaiian Pacific Islanders. So this data includes deaths from February 1st to September 12th, so a couple weeks old. And to orient you to the graph, the x-axis has race ethnicity groups, and the y-axis is proportionate mortality, which is our measure of burden of COVID-19 disease. And that's calculated as the total number of COVID deaths divided by the total number of deaths overall. And during this time period, there were over 180,000 deaths from COVID-19. And as you can see in the orange bar on the left, in combined race ethnicity, the total proportionate mortality overall was about 9%. And as you move across the x-axis and look at different racial ethnic groups, Latinx has the highest proportionate mortality of all racial ethnic groups, followed by Black, Asians, American Indian, Alaska Natives, Native Hawaiian Pacific Islanders. And the rates of Latinx, Black, and Asian communities are, 2 to 3 times that of non-Hispanic whites, which is about 7%. Again, this data confirms the higher COVID-19 burden among Latinx, African American, American Indian, Alaska Natives, which has been previously shown, but adding more evidence to the burden for Asian Americans, which really has received little public attention. Again, though, I do want to draw attention to the highest bar in this graph, which is on the far right side, and that is of the unknown racial ethnic category. So for a quarter of the people who have died from COVID-19, we do not know the race ethnicity. Again, highlighting the inadequate nature of the data that is currently available to us. And these inconsistencies can lead to misclassification by race ethnicity and really make it difficult to estimate the true burden of disease, especially among communities of color. One of the other unique aspects of this data analysis is really the ability to look at COVID-19 burden across the lifespan. So the x-axis here is age groups among Asians. And again, the y-axis is the same, proportionate mortality. And as you can see, there's an increasing trend of proportionate mortality as you increase in age. And the asterisks on the chart means that the age groups are statistically significantly different than the respective age groups among non-Hispanic whites. And so while early reports highlighted higher mortality and morbidity among older adults, younger groups have definitely gotten more attention recently, particularly among communities of color. And there have been a number of hypotheses about why this might be, why younger Asian Americans in particular may be more at risk, maybe potentially higher representation of Asian Americans in the essential workforce, higher representation and having more medical comorbidities, for example, living in multi-generational households and the challenges in physical and social distancing, and importantly, potentially facing xenophobia and not wanting to seek testing or treatment for fear of stigma and xenophobia. But future studies really do need to look at this and explore this further. Lastly, I wanted to show some data from UC CORDS, which is a COVID database that covers 5 UC health systems: Davis, Irvine, Los Angeles, San Diego, and San Francisco. And in the database, we have about 200,000 patients who've been tested for COVID. Again, racial ethnic groups are on the x-axis, and the percent of those tested is on the y-axis. And as you can see, even though communities of color bear a disproportionate burden of COVID-19, only a small proportion have been tested. I know there are some local and community efforts to increase testing in communities of color, but definitely needs to be more standardized at the state and federal level. And I would like to end with this slide, which is borrowed from my mentor, Dr. Tung Nguyen here at UCSF, highlighting a lot of the same issues we've been dealing with for Asian American health data for a long, long time. Although there's been a national push for reporting detailed race ethnicity data for COVID-19, we found that Asian Americans are really being left out of that conversation. And to better understand the epidemiology of COVID-19, to ensure targeted health education and equitable allocation of healthcare resources for vulnerable populations, we really need accurate, disaggregated data by national origin and primary language. So thank you again for having me here today. My contact information is on the slide. Please feel free to reach out and connect. Thanks so much.
Great. Thanks so much, Shannon. That was awesome as usual. And we'll save questions to the Q&A and go straight on to Dr. Monica Fung. Dr. Fung is assistant professor in the Division of Infectious Diseases and Department of Medicine at UCSF. And she's also one whose career I've seen blossom over a very short period of time. So thanks a lot, Dr. Fung, for sharing your presentation on the infectious diseases issues related to COVID-19, specifically looking at transmission, testing, vaccines, and where we are in treatment.
Thank you, Dr. Chin Hong and Dr. Lau, for allowing me to speak today. As Dr. Chin Hong just mentioned, I have been tasked to describe in a very short period of time COVID transmission, clinical manifestations, testing, and therapies. And so I've summarized to the extent possible, but of course, I'm very open to questions during the Q&A session. So I'd like to start off with some definitions, just so everybody is on the same page. I'm sure everybody is aware that SARS-CoV-2 is the name of the virus that is causing the current pandemic. It is a virus that is highly related to SARS-CoV, which caused the SARS epidemic, as well as MERS-CoV. SARS-CoV-2 infection refers to any ongoing viral replication in the body that can be detected, and that ranges anywhere between asymptomatic to pre-symptomatic, symptomatic, and then also patients who are after their symptoms. COVID-19 is colloquially what has been used more commonly, and that refers to the disease caused by infection with SARS-CoV-2, which can really vary quite a bit in severity, and I will go into more detail. Anywhere between mild, with no need for any seeking healthcare, moderate, which requires admission, to severe, which requires ICU care. So a big topic of discussion recently has been SARS-CoV-2 transmission. This is a great figure that is from Galbage et al. From Frontiers in Public Health. And what it really emphasizes, I think, the takeaway here is that the mainstay of SARS-CoV-2 transmission is that middle red area, which is droplet transmission. So the way that often a lot of other respiratory viruses are transmitted. And so you really have to be greater than 6 feet of distance, and the particles are not considered to be sustained in That is the mainstay of what we know is clinical transmission of SARS-CoV-2. Of course, there have been other kind of concerns. The first one is fomite transmission, where an infected individual, their secretions, get onto an inanimate object such as a doorknob or an elevator button or a table, and then somebody can come in contact again with that inanimate object, and then touch that object, touch their face, and then get the infection. What we know is that the virus does sustain on these surfaces. There's data suggesting it, but widespread transmission from people touching the same doorknob or same table hasn't been well documented. And then I think the big topic of discussion recently is aerosol transmission and whether or not that occurs. So aerosols are these smaller particles that can be sustained in the air. And the concern is after somebody who's infected leaves, if you have aerosols with the virus that can stay around, then that can lead to much more widespread transmission. What I will say is that the current data on aerosol transmission of SARS-CoV-2 is not sufficient to let us understand what is going on, but in general, it's not thought to be a mainstay of transmission. The concerning data is that they have been able to find viral particles in the air, in hospitals, like in the ventilation system, for example. But on the other side, as we know that hospital workers who are wearing air droplet precautions, but not airborne, like an N95 mask, they haven't really gotten infected. And then, of course, there are also certain behaviors. I'm sure everybody has heard of the choral practice where a ton of people got infected. There's certain behaviors that are more aerosol generating. So that's a concern as well. But of course, most of us aren't walking around singing at the top of our lungs all the time next to people. And so I think much is to be learned about aerosol. I'll move on and talk a little bit about symptoms of COVID-19. I think the figure on the right basically shows that COVID-19 can involve pretty much any part of the body. But I would like to move to the left of my slide and first of all talk about how we actually know right now that a lot of people don't have symptoms. 40 to 45% of infections are actually thought to be symptomatic. And then move back to what I discussed before. Symptomatic infection really varies between mild to critical or severe. And you can see the breakdown on the left. Most people, 80% have mild infection, whereas 15% require hospitalization and then 5% require ICU for additional, more aggressive oxygenation therapy. Of the symptoms, I'll just go through. Fever is the most common. Often people will say that they have myalgias and fatigue as well. Another common presentation is having shortness of breath and cough, but certainly not everybody. And then all other systems really can be involved. You can have diarrhea, nausea, vomiting. We've all heard about the clots, the increased risk for venous thromboembolism associated with COVID. We've also all heard about the loss of taste and smell. That many patients experience. And then I will say, there's going to be more discussion about cardiac manifestations, but also people have been reporting to have cardiac injury as well as acute kidney injury. But it's a little unclear if that's just related to the degree of illness. This slide shows the overall clinical course of COVID-19. As with most infections, there's this incubation period where people don't have symptoms. And that is felt to be around an average of 5 days. And then in the first part of illness, people tend to present with fevers, cough, loss of taste, smell, as I mentioned. And then after that, the second week onwards, that's when they can have the manifestations of more severe disease where the virus moves down into their lungs. They may require. And then, of course, increasing reports are telling us that people have symptoms quite for a while after their COVID-19 illness, and lots of studies are ongoing, including here at UCSF, trying to elucidate the mechanism and pathophysiology. I also just wanted to show another figure that kind of that shows us what's happening within the body. And what we know is that early on in infection, there's this early infection phase where the viral response predominates. And so there's lots of virus in the system. So our immune responses to the virus, and that's when we're trying to target the virus there. In the middle, that's where you're starting to have the virus go into there's more viral invasion, but also the immune system is ramping up. And then we've all heard about kind of late stages where the host immune response is what's predominating, and you can get syndromes such as cytokine storm or multi-system inflammatory syndrome in children, where it's kind of our immune system going awry. Just mention here kind of the more susceptible groups in terms of more severe disease. We are all most aware of this: older age, men, and then chronic medical problems such as hypertension, diabetes, obesity, heart and lung disease, and then patients with cancer. And I would say the more of these that you have, it adds up. I'll move on here to talk about testing. There are a lot of, I feel like, always COVID tests that are kind of coming out. The kind of two mainstays of tests are our PCR test, which is looking for the nucleic acid of the virus, as well as antibody tests. And then there are also antigen tests. I think in terms of how to interpret these tests, it's really important to think about where is the patient and their disease. And so basically what we see in the red line is the amount of virus that's, for example, in the respiratory tract, or the blue lines in the nasopharyngeal tract. And if you think about how much virus is around, that'll tell you about how long that PCR test can tend to be positive. And then the antibody test, what we know, the purple line and the green line tell us what happens with our antibody responses to the virus. We generally don't see the antibodies mount until about the end of the first or second week of illness. And so certainly if somebody has COVID-19, they would have early on their antibody test could be negative. And then the key thing about this is actually the IgM and the IgG. The IgM, which we normally think is earlier on infection, they tend to actually rise around the same time. So as an infectious, so we don't typically recommend that. And then just to mention that there are new antigen tests that are out there. A lot of them tend to be rapid tests. Overall, even though there's a lot of variability, they are considered less sensitive than the PCR nucleic acid-based tests, though they are rapid. And so they may be considered for use depending on the clinical. And this is my slide on COVID-19 therapies. I will walk you through. The blue highlights the therapies that have had large-scale randomized control trials that have demonstrated efficacy. The black are ones that are still being studied. And then the reds with lines through them are the ones that we really have kind of proven data, good, large, also randomized control studies that have demonstrated limited efficacy, so not recommended. So thinking back in terms of COVID and the timing of infection and our immune response, we have our antivirals, which kind of target the virus earlier on in infection. Remdesivir is an antiviral. You can see here is published in the New England Journal. The preliminary report demonstrated earlier time to recovery and earlier time of symptom resolution with the use of remdesivir. There's also convalescent plasma, which is, many of you may be aware, basically you collect the plasma from a patient who has had COVID-19 and infuse it into a patient with active COVID-19. This was recently approved by the FDA, though there has not been any large-scale randomized control studies that have demonstrated benefit, and so it is not in any guidelines right now as definitively recommended. And then we've all heard about hydroxychloroquine and protease inhibitors, and there was a lot of excitement early on for these agents, but the large studies have demonstrated no benefit. currently not recommended. And then interferon alpha or beta, which acts both as an antiviral as well as an immunomodulatory, is currently being studied in studies, and it does hold promise. Another question is about so the next category, I apologize, is immunomodulators, which targets kind of the later stage where, as I mentioned, the immune system kind of goes awry, and this is when you have cytokine storm, etc. There was a large study also shown here, the recovery study, demonstrating that steroids had significant benefit in mortality. This was not given with remdesivir, so whether or not steroids plus remdesivir will lead to the same amount of mortality benefit is but that is part of what we use at UCSF. Convalescent plasma is also considered a bit of an immunomodulator, and then of course JAK or cytokine inhibitors are also being studied. Currently, there is not a single agent that has been definitively proven to be helpful, like to solicit. And then COVID-19 prevention, another hot topic in the news these days. I will just quickly say that in terms of prophylaxis, and specifically post-exposure prophylaxis, there is no known effective intervention. The main one that has been studied is hydroxychloroquine, and the randomized controlled trial did not fit, so it was not recommended. There are other monoclonal SARS-CoV-2 antibodies that are being studied, and then the overall recommendation is really you should only be getting trials. Finally, vaccines. There are many vaccine candidates, of which some of the most promising are kind of mRNA and DNA vaccines. There are also vector vaccines and activated vaccines, and some people consider using BCG the therapy. There are large-scale studies, as you are all aware, underway right now, and we look forward to seeing those data, and everybody is hoping that we will have an effect. So I will stop here and let's move on to our next speaker.
Great. Thanks a lot, Dr. Fung. That was great. A whirlwind presentation in infectious disease issues. So our next organ is the heart. And we have the dynamic duo of Dr. Gordon Fung and Dr. Eugene Yang to present. Dr. Yang is professor of medicine in the Division of Cardiology at the University of Washington. Luckily with COVID, he doesn't have to fly down, but I know he would have wanted to come to San Francisco anyway. And Dr. Fung is the professor of medicine, Division of Cardiology, cardiovascular medicine at UCSF. Take it away, and thanks for teaching us about the heart cardiovascular complications with a focus on Asians.
All right. Welcome to the cardiovascular manifestations and COVID-19. Dr. Eugene Yang and I will be splitting this. And we picked a couple of topics that are currently very heavily discussed in the literature. And the first one that I wanted to go over was the acute coronary syndrome. And then we'll follow that with some of the articles that are looking at thrombotic complications, and then finally, for me, the increased risk of stroke. With regard to the acute coronary syndrome, shortly after the shelter in place was put into place, and so you see this particular red line here, and in this upper left-hand graph, you see admissions to the hospital per week of any acute coronary syndrome. And there was a significant decrease. Some hospitals were reporting up to 60% reduction in acute coronary syndromes, and it would range from 40 to 60% reduction. Now, this was an article that looked at the entire National Health Service in England. And so you can see with the large database that they were able to separate out any acute myocardial infarction, STEMIs in the lower left, and then non-STEMIs in the lower right-hand corner. And you see a significant change. This suggestion at that point in time was, wow, this sheltering in place must really work. People are not going out to eat very heavily salted foods, and they're not having to deal with the stress of traffic and commutes and working in places where they may not be so happy. That the stress reduction was also a side benefit of having shelter in place. Unfortunately, that did not turn out to be entirely true. And so you see from this article here, looking at two hospitals in New York, that there was a significant rise in out of hospital cardiac arrests going on. Now, this was a significant rise, and it was more than the average out of hospital cardiac arrest. So it was felt that the COVID-19 was also contributing to this. But it was then later surveyed and found that one of the biggest problems, and that's was that people were just afraid to come to the hospital. They were afraid that they would not have access. They were afraid that they were going to be treated a little bit differently, that there was going to be further delays. And so I think that this is a major point for this medical community, that we need to actually continue to educate the population, especially the diverse population that feels that there is the social determinants of health, of accessibility, and that the hospitals are safe and set up for receiving patients. One of the things that we're starting to see with these outpatient or out of hospital cardiac arrest, if we go back, you see that it actually started to improve and people are starting to come back. But as people are starting to return to the hospital with ACS, we are seeing a number of reports of major complications due to delay in presentation, sometimes up to 2-3 days. And so they're coming in with complications that we have not seen since we instituted immediate PCI intervention with as a treatment for acute coronary syndrome. And so patients coming in with cardiogenic shock and multiple delayed complications from ACS. So it is very important that we continue to educate our population about ACS and the need for immediate management. That is the only way that we can continue to see a reduction in cardiovascular mortality and morbidity from this deadly disease. The next topic that I wanted to go over was the issue of thrombosis. And so, as you know, there have been a number of reports suggesting that there was increased venous thromboembolism, pulmonary emboli, myocardial infarctions. We can add ischemic strokes to this, as well as DIC. As Dr. Fung talked about earlier, there are a number of inflammatory responses that could be going on in the body at the same time. And so it causes a significant number of hemostatic abnormalities, including microthrombi and intravascular coagulopathy. The myocardial injury from thrombosis, increased cardiac markers. One of the interesting things that was found, at least for me, because I don't use this test very much, is the D-dimer, and that seems to be elevated in most patients with presenting with COVID-19, but it's been found to be a major predictor of ICU hospitalization, strokes, and MIs. as well as pulmonary emboli and ultimate demise from the COVID. It is so common that it is believed that if you get an elevated D-dimer, and that's usually 3 times the upper limit of normal, then that is the predictive of bad outcomes and more severe hospitalization. So that is something that also the major societies, the ACC, the American College of Chest Physicians, also are not recommending that if you have a D-dimer that you automatically jump to rule out venous thromboembolism like a PE and do CT scans for that. But that you keep an eye out for it. It's just now considered a marker of severe disease. So this was a study looking at the number of complications, both in ICU settings and in non-ICU settings, the total hospital population. And you could see that pulmonary emboli, DVT, strokes, MIs, and other thromboembolisms were all elevated. In the ICU setting, the events of thromboembolism was also increasingly elevated, even more so than the non-ICU patients. So the current recommendations are that we see a graded, gradual increase in risk for thromboembolic complications. Certainly, at this point in time, we have no way of evaluating or intervening on the asymptomatic, untested or tested population. But the first recommendation comes in the mild COVID-19 patients who have all these risk factors. And it is recommended that anytime you have a patient who's hospitalized, that they undergo a VTE of venous thromboembolism, a risk score to determine whether they're high risk or low risk of developing thromboembolism. But for the mild COVID patients that are basically quarantined at home, in the maybe even in the hospital, but not in the ICU, the recommendations is to quarantine at home, but stay active. People who have access to things like compression stockings, the serial compression stockings as well are certainly encouraged to use that. But being active is one of the best things. Then anytime a patient is hospitalized with moderate or severe, standard VTE prophylaxis with unfractionated heparin or Lovenox, depending on the complications, and the use of mechanical serial compression stockings is recommended. There have been trials done on higher doses of the heparin and anticoagulation is certainly what we want to, and they have not been shown to be better, and they're all done at the risk of increased bleeding. So we want to prevent COVID-19 death. Now, the final topic that I wanted to cover, and I asked our neurovascular team, is what was the most significant article they felt in the last 3 months discussing COVID and the incidence of stroke. And they mentioned this article that was published in JAMA Neurology, and I found it to be very significant. So this is a slide looking at a hospital that had up to 30 patients who had a stroke while they were in the hospital for COVID-19. And if you look at this, the key for this, each line here is a patient. And the orange dot is the patients who had stroke symptoms and ultimately were determined to have a stroke. The gray dot is when they were admitted to the ICU, and the white dot was when they were hospitalized. And what you see here is that 8 of the patients out of the 32 patients actually presented with a stroke. And these patients here, down in the lower left, if you can see my cursor, actually presented 4 days after having a stroke. And so this patient here, the fourth on the top, from the top, was hospitalized, and then 4 days later had their acute ischemic stroke event. Now, it was as long as being in the bottom one, admitted to the hospital on day one, and not even, and then going to the ICU on day 14. But it wasn't until 25 days later, on day 39, that they actually had their acute ischemic stroke. So that the increased thrombosis and event was very significant, and it could occur at any time during the hospitalization. Almost all of these patients had elevated D-dimers, and they all had gone to the ICU prior to having their acute CNS event. I wanted to just look at this slide because I thought, apropos to Dr. Chu's talk about the lack of data, and this is certainly not separated out as such. But if you look at the patients who had COVID-19 and a CVA, the white population was certainly elevated, but not as high as just an ordinary flu season. And then you see that is always talked about that the Black and the Latinx population are elevated, but looking at the Asian population in these two hospitals actually showed that they were just as high as the Black population. And then the other differences you could see, most of the patients who had COVID-19 and ultimately had a stroke had heavily populated hypertension and diabetes and hyperlipidemia.
Dr. Fung, we are at 13 minutes already for the cardiovascular section, so I don't know how much Dr. Yang has to present. But
okay, sorry. So I'll just end up here that with regard to COVID and CVA, it's important to recognize that a stroke has a bad risk factor with the ordinary flu, and the COVID-19 has even a higher risk for stroke. So I'll turn it over to Dr. Yang. Sorry.
So I wanted to highlight a few things Dr. Fung mentioned about COVID-19 and hypertension. So as you probably saw in both U.S. studies as well as studies from China and Italy, hypertension was very common among hospitalized patients and is often associated with other comorbidities such as older age, coronary artery disease, diabetes, and obesity. And so one of the questions that has remained is whether hypertension is really independently associated with worse outcomes or is confounded by these comorbidities. And at this point, we still don't really have a clear understanding of whether it independently is a risk factor. However, what we do know is that the SARS-CoV-2 virus interacts with the renin-angiotensin-aldosterone system. So as you can see here, the SARS-CoV-2 virus attaches to the ACE2 receptor that is found on lung and cardiac cells, and it basically gets internalized. And then what happens that causes some concerns is this interaction with the RAS system, and specifically ACE2 breaks down angiotensin 1 and angiotensin 2, because we know that activation of the renin-angiotensin-aldosterone system can cause things such as acute lung injury, as well as adverse myocardial remodeling, etc. And therefore, drugs that interact with this system, such as ACE inhibitors or angiotensin receptor blockers, which are commonly used to treat hypertension, could potentially cause increases in these ACE2 levels and perhaps mediate increase in potential respiratory and cardiovascular complications. So what we have been concerned about is do RAS inhibitors increase the risk of severe infection? And so we know that there may be some theoretical concerns about increased risk of these ACE2 levels that may facilitate COVID-19 infection and worse clinical outcomes. And there are some animal and human data that suggest that RAS inhibitors that are commonly used, especially in Asian populations for treating high blood pressure, could potentially affect local tissue or plasma ACE2 levels. And I think the final thing that makes it challenging is that cardiovascular complications of COVID-19 are common, including heart failure, cardiomyopathy, acute coronary syndrome, and we often use RAS inhibitors to reduce morbidity and mortality. So we recently published this review in the European Heart Journal, and what we have learned so far is that when you see patients who are hospitalized, who are taking these classes of drugs, that in general there is no impact on severity of illness or mortality. And in fact, there are a fair number of studies that show that patients who are treated with these medications may actually have a lower rate of severity of illness or mortality. And there are a number of ongoing clinical trials that I just highlighted here. So there are studies all over the world that are looking to see whether RAS inhibition is associated with worse clinical outcomes. There's one trial that was just presented at the European Society of Cardiology meeting about 3 weeks ago. And this was the first study that looked at a prospective cohort in randomized fashion of about 660 patients in Brazil, where they were either continued treatment with an ACE inhibitor or angiotensin receptor blocker or temporary suspension for 30 days. And what they found basically was that there was no difference in the primary outcome, which was looking at the number of days alive and out of hospital through 30 days, or secondary outcome, which was all-cause mortality. So it gives us some confidence that using these drugs is safe and reasonable, at least based on the results of this one randomized clinical trial. And as Dr. Fung mentioned earlier, both the European Society of Cardiology and the American Heart Association, the American College of Cardiology, and the Heart Failure Society of America early on addressed this issue and recommended continuation of these treatments when clinically indicated. So I'll briefly touch upon heart failure and cardiomyopathy. So as Dr. Fung showed earlier, cardiac complications are common, and you can see that acute or decompensated heart failure occurred in up to 25% of severely ill patients in Wuhan, with up to 50% mortality. But again, there are high rates of comorbid conditions, as we've already touched upon. A recent study looking at imaging from Israel found that the primary abnormalities that were seen by ultrasound were primarily right ventricular dilatation and dysfunction. Diastolic dysfunction of the left ventricle occurred in about 16%, and only about 10% had evidence of LV systolic dysfunction that was defined very loosely as an ejection fraction of less than 50%, whereas typically we define that as less than 40% for heart failure reduced ejection fraction. But what we did also see is that cardiomyopathy with severe left ventricular systolic dysfunction is relatively uncommon and is associated with other etiologies, including stress-induced cardiomyopathy, cytokine-mediated or sepsis-associated causes of cardiomyopathy. The final thing I'm going to touch upon is subclinical inflammation, and I think that this has been publicized a lot recently, especially in sports. And what we know is that myocardial injury is common and occurs in up to 20% of patients. And in fact, patients who have fulminant myocarditis was suspected in 7% of patients who had fatal outcome. I think more concerning are the subclinical categories of inflammation that can be detected from cardiac MR. And I'll highlight two studies. One is from Fung from China, of 26 previously hospitalized patients with cardiac symptoms, and they didn't have the cardiac imaging study performed until 47 days after their symptom onset. And you can see that more than 50% had abnormal cardiac MR findings, and 54% had myocardial edema or inflammation, suggesting that they may have evidence of subclinical inflammation or myocarditis. And in fact, 31% of the patients had evidence of fibrosis or scar tissue with cardiac MR. A larger study from Germany of 100 patients found very similar results. And in this study, in fact, 2/3 of them were actually not hospitalized. The median time from the diagnosis of their COVID infection to CMR was 71 days. And in this study, 78% had abnormal cardiac MRI findings, 60% with evidence of myocardial inflammation or possible subclinical myocarditis, and 32% had evidence of scar tissue or fibrosis. Of note, about 30% or 40% of these patients had ongoing symptoms at the time of their cardiac MR that is reported here. And I think the key question, especially in light of college athletics, where a recent study from Ohio State showed that over 50% of the student athletes had evidence of both ongoing inflammation as well as scar tissue, is of significant concern. And at this time, we really don't know what the long-term impact of these findings are for the cardiovascular risk associated with it, and studies are needed to really answer these questions.
Great. Thanks so much, Dr. Fung, Dr. Yang. And hopefully we'll make up some time with our final presentation of the first section with Dr. Descartes Lee, who's professor of psychiatry at UCSF and published medical educator. Dr. Lee, hope you can work some miracles here and get us back some time in your presentation on mental health and racism, actually a really important topic, particularly amongst the Asian American community. I would say that I've personally been very troubled by all of these reports during COVID.
It's no disclosures except that I'm Chinese American. I guess that means I'm against racism and xenophobia. As a background comment, so the outline of this talk is we're going to talk a little bit about the background, the context in which all this has occurred, this China versus US thing. Then I'll talk about the impact of the pandemic on Asian mental health. Hard to know because we don't have that much data, but I'll cite a couple of indirect lines. And then finally, what you can do, and kind of I have just in this PowerPoint some resources. So I will try to be fast, and people can access this PowerPoint later if they want to click on the links and the resources and stuff. So let me just talk a little bit about what's been going on that many of us are aware of. That China, there's been this China versus U.S. kind of a brewing conflict in the background, and I myself, as a person, kind of I'm happy being a psychiatrist, and I like to talk about how we can minimize side effects of lithium and stuff like that. So it takes a lot for me to kind of back up a little bit and think about these bigger picture things, and I often kind of prefer not to. But unless you've been kind of completely cut off from the news, you've been hearing about Chinese-U.S. competition ongoing and for the past year or so. And the context is that China is being viewed as a long-term strategic adversary to the United States. This is a comment by Mike Pompeo, Secretary of State, that China represents a threat to our continued democracy. And a comment by Kyron Skinner, who I thought was very interesting, and this is in April of last year.
But China, we see it as a more fundamental long-term threat. That's not, I think, a partisan issue. And one of the ways in which Donald Trump has contributed to a bipartisan foreign policy consensus is on China. Because at the start of his presidency, there wasn't the kind of understanding that China is the long-term threat. It is a real problem. It's also striking that's the first time that we will have a great power competitor that is not Caucasian.
It's the first time we'll have a great power competitor that is not Caucasian. So what are the implications of that? Now, Europe and other people are very concerned about this, and actually an outside perspective of this is that the U.S.-China rivalry has become the focus of international relations for the past 2 years, and this rivalry kind of shapes strategic debates along political, military, and economic dimensions. And so I'm not going to read the rest of the slide, but just how this competition can actually cause a lot of damage to global institutions, and also how Presidents Trump and Xi both can foment these bilateral conflicts and, in a way, degrade international rules and institutions, and how Europe is really trying to avoid getting it trapped into this dynamic. Now, President Trump has repeatedly called it the China virus. He claims that it's not racist. I have to say that he did make a comment about that Asian Americans would not be discriminated against or should not be discriminated against, although I have to say, sometimes actions speak louder than words. Many Republicans are blaming China. So this is basically this is a quote from Martha McSally saying China is to blame for this pandemic and the death of thousands of Americans. There was a House resolution recently, thank you, Diana, for this, that called for the end of condemning all forms of anti-Asian sentiment as related to COVID-19. The vote, unfortunately, did break down along party lines. So that's the background. That's the context that we go into this pandemic with as the China virus. So what about the actual impact on mental health and on Asian mental health in particular? We do know that at least among health workers in China who were exposed to patients with COVID-19, the quote-unquote frontline workers, 50% of them reported depression. And a study of medical students identified in China reported elevated levels of moderate to severe anxiety, 3.6%. So obviously Asians are vulnerable to the pandemic effects of mental health. And then on another line, does COVID pandemic affect mental health in general? So this is a study from the UK showing that people in, let's see if I can, I think this mouse is actually working here. The 27% rate of kind of testing positive, screening positive for mental distress based on their screening tool, the general health questionnaire. Versus kind of the baseline you can see here is usually around 16 to 18% will say they have significant mental distress, and we have a bump in April. And this is a study from the UK. So what about the United States? Here, the United States is a study across the United States, a nationwide study looking at in the blue bar before COVID, the dark blue, and then the lighter blue in April of 2020, looking at it during the COVID. So before, the number of people with no depressive symptoms went down. So, and then with mild, moderate, moderately severe, and severe, it went up. And this used the PHQ-9, which many of you may be familiar with, and this is the scale that they use. So it is pretty significant that many people scored in the moderately severe to severe, clearly higher than it was pre-COVID. This is kind of meant to be a joke. How might COVID affect dental health as opposed to mental health? This is a relatively brief talk, so this will be over soon. So this joke is, if you don't like it, that's okay. But I like how the teeth have little lightning bolts. But anyways, this is an anecdotal report by a dentist who reported more cracked teeth, and his kind of idea was that people were grinding their teeth a lot more from all the stress that was going on. So how might COVID affect mental health? What is like the intermediate steps by which it actually could affect mental health? And this kind of non-specific question of increased stress is hard to say, but things like social isolation, impaired access to healthcare, lack of exercise, and all of these contributing to exacerbation of pre-existing medical conditions. There's also some very interesting ideas or hypotheses about the direct neurological effects of SARS-CoV-2 coronavirus on the central nervous system. I'm not going to go into details, but I find this kind of stuff really fascinating. There's a link to a review article there. And what about this issue of racism and xenophobia and increased stigmatization? Now, we already know that Asian Americans had a kind of a mental health crisis in terms of access to care and so forth. And could this make the racism and stigmatization of coronavirus make it worse? We do know there's been an uptick in reports, and I've just listed a bunch of different newspaper articles here available for anyone who wants to look at them. There is a website that asks people to report on assaults or harassments, and there were over 2,500 racist incidents reported since March, and this report's from August. So of the incidents, 70%, 7 out of 10, involved verbal harassment. 9% were actually physical assaults. 8% involved workplace discrimination and being barred from establishments or public or kinds of transportation. Women reported discrimination at 2.5 times the rate that men did. And now the majority of reports are from California, 46%, although California obviously has one of the highest Asian populations. These are just some other editorials that I'm not going to go into detail now, but I found really interesting for people's edification about how other ideas. I think there may be some discussion of intimate partner violence in COVID. Now, Asian American population is kind of well documented as having relatively high rates of intimate partner violence. In Europe, there was a 60% increase in emergency calls regarding intimate partner violence based on World Health Organization. Some of the ideas are that interpersonal violence victims are required to stay the whole day with their partners and away from help. And so there's an acute need of resources to manage and attempt to prevent crisis situations. Here's some more information about that from the CDC, actually, and the WHO. So now that I've talked about, we have the big context. We know that mental health symptoms are going up. We know that Asian Americans are probably at the target of greater discrimination and racism. So I don't think it's a big leap to say that, there may be, or there's high likelihood that Asian Americans are under much greater mental health stress. But we don't have direct data on that just yet because we don't have as much data from before to compare it with. But I feel comfortable saying it's not a big leap. So basically, what can you do and what resources are out there? This is a good review article, but encourage individuals of Asian descent to reach out to one another, introduce mindfulness techniques, make sure you screen for psychiatric disorder. There's a lot of literature out there describing the Asian American experience. They're all really wonderful many wonderful pieces out there. Disseminating resources, suicide prevention, making sure that the caregiver is being cared for, and to prevent burnout, and as I mentioned before, interpersonal violence interventions. If you get a chance, you can submit your, if you have experiences, one way to empower yourself is to submit an incident report through this link here. I'm very proud to say that the Department of Psychiatry has developed a really nice, free, open to the public coping resources link. So anyone who is interested can click on this. Tons of videos, tons of things you can look at, not necessarily focused on Asian American populations, but very helpful for anyone who's interested. I really love this interview with a podcast with Dr. Eric Tang. Talked about COVID as a possible turning point for Asian Americans. Asian Americans may be the scapegoats, but as this symposium may indicate, that many of us are in the healthcare professions. So how do we reconcile this Asian American as kind of the hero and the scapegoat as well? And maybe this is an opportunity for us as Asian Americans to really try to come together. So that's really it. Thank you so much. Just again, there's a lot of stuff going on, and I just hope that some of these links will be helpful to you and resources.
Thanks a lot, Descartes. That was great. I'll definitely make sure to take care of both my mental health and my dental health during COVID. And really nice resources. So without further ado, I think we've made up some time now. We can go on to the panel and try to address some of your questions. And we have a few questions that we've had submitted previously as well. Monica, would you want to answer a few questions? Some of the questions were about how long will immunity last during COVID? Can you answer that quickly?
I think the short answer about immunity and COVID is we don't really know. There are some promising studies. So just to back up, our antibody tests, they look at antibody-specific parts of the virus, but do not necessarily look for neutralizing antibodies, the antibodies that actually attack the virus. So initially there was some concern about whether or not antibody tests actually measured that. There are some more recent studies that suggest some correlation, but how long these neutralizing antibodies last, we don't know. Probably a few months, but okay. I think everybody's probably aware there have been some reports.
Great, thanks so much. We have a question for Dr. Andrew Ko. Dr. Ko is Professor of Medicine in the Division of Hematology and Oncology. Dr. Ko, at UCSF, how has the COVID-19 pandemic affected care of cancer patients?
I will say that when the COVID-19 pandemic hit, this led to a lot of soul searching amongst our cancer providers at UCSF and really nation and worldwide, because obviously we're already taking care of a very sick patient population and trying to delay care or I'll say prioritize care really led to a lot of debate, both clinically and ethically, about the management of individuals with cancer. And not just UCSF, but other places tried to establish a prioritization, a ranking of sort. And you can see how that's already fraught with so much difficulties. This is just one example that I'm showing here from Ontario Canada Group in terms of how they deemed cancer care from lowest to highest priority. And I'll just point out that for a lot of patients that I see who have advanced metastatic disease where they're receiving treatment in the non-curative setting, the care of those individuals in the height of the COVID-19 pandemic was really on the lower end of priority. So if we were thinking about patients who would be allowed to be seen and cared for at our cancer center, the priority really was on folks with potentially curable disease, where there was a lot of time sensitivity, and as opposed to in the palliative or life-prolonging setting. And now, obviously, this is just very difficult as we're trying to advocate for all of our patients. Some of them, I will say, didn't want to come in anyways. And you can just imagine the repercussions in terms of cancer progression not being seen in a timely fashion. Now, this included patients scheduling surgeries for patients. So procedures and surgeries really were delayed, except for the most urgent ones. And whenever possible, patients' operations were delayed, and we would try to bridge them, for example, with some systemic therapy, sometimes oral therapy. Aside from the treatment aspect, you can envision the impact on, and so there's been a lot of discussion on cancer screening, where patients screening, colonoscopies, et cetera, have been or were delayed, and sort of the repercussions in terms of catching cancer at early stage disease. It had a huge impact and continues to in terms of clinical trial enrollment, end-of-life care. The visitation policy, I think this affects all of our colleagues, but you can imagine when we have goals of care discussions with our patients, and they have to come alone because we can't have family members present there. Had a tremendous impact in terms of our discussions. So this really, so the impact of COVID had and continues to have just a tremendous impact on our cancer care from the very early stages to sort of the very late stages of illness. I'm not going to show too much by way of data slides, maybe just a couple of things, and that's to point out that early reports from China suggested that patients with cancer might have both a higher risk of COVID-19 as well as more severe events associated with COVID-19 infection. And that includes death and mechanical ventilation, ICU level care. This may not be quite as straightforward an answer as you might say. And in fact, there's been actually quite a lot of mixed data from internationally as well as in the United States, particularly in hard-hit areas, in terms of whether patients receiving active cancer treatment really are at higher risk, as we've all been worried about, in terms of either developing COVID-19 or the severity of it. A couple of cancer types, and perhaps not surprisingly, that do seem to be associated with worse outcomes from several studies include lung cancer, as you might imagine, individuals with pre-existing respiratory compromise, as well as hematologic malignancies. And then I'll just finally say that there's, just as a shout out to a very large cancer consortium called the CCC19 Registry, which is ongoing right now. And this is just an international cohort to try to get to some of these questions in terms of both active cancer patients as well as cancer survivors in terms of the impact of COVID-19 on their disease trajectory. And this was just an initial report out of Lancet on the first 900 plus patients. And you can see the factors associated with a higher 30-day mortality in this cancer patient population. And these aren't really very surprising. Older age, male sex, smoking history, poor performance status, and having active as opposed to already treated and essentially cured cancer. So these are the factors that seem to stand out in terms of higher risk of severity. So I'll stop there. I'll just point out that we take immense precautions, not just at the Cancer Center, but UCSF-wide, to try to reassure and convince patients that they can come, they can receive their treatment, and they will really be at very minimal exposure to COVID-19 while they're at our cancer center. Thanks.
Great. Thanks a lot, Dr. Ko. We'll have the next slide up. We'll move through these questions pretty quickly. And as the next slide goes up, I have a question for either Dr. Chu or Dr. Don Eng, who is one of our great faculty in the Division of General Internal Medicine. The question is, how have Asian patients fared during COVID-19 who are in nursing homes and long-term care facilities?
I don't have any data on the nursing home patients because I don't nursing home rounds, and I'm not sure if Janet has any more of the data. I think what's hard for them is that the lack of visitors. A lot of my patients who had gone into nursing homes, they have family members actually provide care for them when they feel that the nursing care in these nursing homes are insufficient. With the onset of the COVID-19, the visitors are not allowed, and I think that makes for the residents in these nursing homes be more depressed, more isolated, and probably do a little worse. And I don't know, maybe if Dr. Anderson-Ng, whether or not you do any nursing home rounds, that perhaps you might know of that.
Anderson, do you have any quick comments? We'd love to hear your thought on how Asian patients have fared in nursing homes during COVID-19, feeling isolated.
I don't do any rounds in the nursing homes, but I did have patients that were admitted to ALS after being hospitalized, and there was extreme isolation. A lot of my older patients are monolingual Chinese and not even Cantonese, and they would at times call their son, tell him to take him out of the ALF. So there is like a strong sense of isolation for the older population, especially the monolingual Chinese, where staff at the ALF or the doctors themselves, they don't have that language capability to communicate with the patient.
Have people used FaceTime in the nursing home for these monolingual patients? Have they embraced technology or just the phone?
A lot of times, the older patients, they have the clamshell phone. So a lot of it was the phone interactions with their family to get them through their hospitalization or SNF stay. So technology.
Yeah, thanks, Anderson. That's awesome. So next question is to Dr. Sarah Kim, and Dr. Kim is on faculty at in the Division of Endocrinology, and Dr. Kim, why do patients with diabetes get infected more easily in COVID? We noticed that diabetes is always one of those comorbidities that shows up in multivariable analyses for mortality with COVID.
Yeah, so it's a really good question. So actually, when I looked at the literature for the rates of just COVID positive tests among the population with or without diabetes, it actually seems that just being positive, just having a positive test, it is not more frequent in people with diabetes. And there's actually one large study that came out of China for about 1,500 patients tested for COVID, and the positivity, the diabetes rate amongst that was about 8%, which reflected the prevalence of diabetes amongst that population. However, it is very clear in multiple studies from not only Asian countries, but countries like in the US and Europe, that having diabetes is a risk for severe illness. So it's a risk for needing hospitalization. It is a risk for needing ventilation, ICU care, and even death. So that is clear. I do have a little bit of a slide on this, but I don't have to show it. I mean, the bottom line is that the mechanisms for why people with diabetes have a more difficult course with COVID-19 is probably multifactorial. Number one, they often have concomitant risk factors like obesity, which has also been shown to be a risk factor for more severe COVID illness. They have hypertension. They tend to have OSA. Their existing diabetes complications will also, confirm more severe illness. If they already have a bit of CKD, they already have cardiovascular disease. People with diabetes have been shown to have poorer immune systems and higher degrees of inflammation. And diabetes is also a prothrombotic state. So you've heard from all the lectures that have led up to now, how high thrombotic state, inflammation, and heart disease can all sort of increase your risk of severe COVID course. And then, the association with the ACE2, people with diabetes again have more hypertension, and ACE2 might be playing a role with people with diabetes, but that's theoretical, I suppose, at this point. So people with diabetes have a more severe COVID course for many of those reasons.
And quick second part question is, once they're hospitalized, do you just get called to maintain tight glucose control, or are you more lax in the hospital with glucose control when they have these critical illnesses?
Actually, no. The data suggests that if people if they were able to maintain euglycemia in the hospital, they'd have a better course. So actually, you should be very careful with the glucose management, as you would with anyone in the hospital, but especially with people with COVID-19. And there's also some interesting data to suggest that, your baseline A1C can predict a more severe course in the hospital.
Great. Thanks so much. That was awesome. So I have a question for Dr. Yang, Eugene Yang. Do you know, you may not know this answer, but one of the questions was, what's UW doing in terms of screening of learners? So residents, fellows, medical students. I could talk about the UCSF experience.
Dr. Chin-Hong, yes, I did answer the question. I'm not familiar with that particular question. I don't think we're routinely testing the students or even residents and house staff. I think only if there's been some clear exposure or symptoms have we been testing both the faculty as well as students. There is, I commented on this, there's an ongoing study looking at sort of exposure and prior infection. So all healthcare workers, including staff as well as the providers, are all getting antibody tested, as well as family members, just to see, what the actual rates of exposure and infection have been.
Great, thanks. And at UCSF, just very briefly, we did screen all medical students at the beginning and residents coming in, but during the time that they're here, they're not being routinely screened unless they have symptoms, as Dr. Yang said. Our next question is for Dr. Ann Chang. Dr. Chang is on faculty at UCSF in women's health. And the question, Dr. Chang, is, how has the COVID-19 pandemic affected women's health? And the second part question is about pregnancy. So can you address those questions?
Sure. So there have been a lot of topics about women's health and how the COVID-19 pandemic has affected. So I wanted to present some slides on sexual and reproductive health, domestic violence, and then also how the economy has affected women. One of the things, let me address the question about the pregnancy first. So for pregnant women, COVID looks like it has higher rates of, gives women higher rates of preeclampsia, preterm birth, and perinatal death. And seems like that pregnant women may also be more susceptible to severe illness. And also the virus may be transmitted to the fetus during pregnancy. Data does suggest that it is not likely that mothers with COVID can transmit the virus via breast milk. So I first like to discuss about domestic violence globally and in the United States. Some of the countries have reported increase in domestic violence during the lockdown period. Females are disproportionately affected by domestic violence. In March, in Argentina, women were killed at the hands of a partner every 29 hours, which is 4 more than the monthly average. In late March in Malaysia, there was 57% more calls to the domestic violence abuse helplines. There was also a disparate response to domestic violence prevention among countries, where some countries ignore the domestic violence issues and other countries increase funding for domestic violence. In the United States, in some cities, there was up to a 5% increase in domestic violence crime rate, like Chicago, LA, Kansas City, Memphis, New Orleans. Also, there was some evidence of slight increase in murder-suicide rates, which male partner kills a female than himself. However, total domestic violence rate has fallen in the United States since COVID, and experts think that this is a problem with reporting, since teachers, daycare centers, and social workers have been unable to identify and report cases. Next, I wanted to talk a little bit about sexual and reproductive health in the world and United States. The COVID-19 pandemic has disrupted sexual and reproductive health services like all global health emergencies. So community clinics are closed and all healthcare workers are moved to help in the overwhelmed local hospitals. This leaves females without contraception and easily accessible abortion services. It is estimated by the UN that this will lead up to 7 million unintended pregnancies and 2.7 million additional unsafe abortions. In the United States, in the early days of the pandemic, 12 states classified surgical abortions as an elective, non-essential procedure. Most of the delay in surgical abortions are no longer in effect. However, this delayed women who want abortions to get one. One of the benefits of the pandemic is that now we have many more telehealth visits. And this has changed the delivery of medical abortions and prenatal care services. And because we are doing many more things from home, demand for midwife services for home births have also increased. The pandemic has restricted access of family and partners during labor and birth in the hospitals. And lastly, it is estimated that COVID-19 can cost the global economy $8 trillion US. All countries have adopted fiscal measures to mitigate the economic downturn. Only 16 out of the 195 countries have reported new or amended social protection measures that make reference to women. Women working in the informal economy in jobs such as domestic worker, home-based work, or family business are more likely than men to suffer from economic hardship and face exploitation. Unemployment due to COVID-19 is highest in the service industry, which has a disproportionately higher number of women employees like hospitality, travel, education, and retail. And this is also true in the United States. Due to distance learning and shutdown of daycares in the United States, this makes it particularly hard for women to balance childcare and work.
Thanks, Dr. Chang, for all of those sobering statistics. The next question is for Dr. Anderson Eng. He is a fabulous clinician. He's based at Chinese Hospital in internal medicine. The question, Dr. Eng, is, how has the COVID-19 pandemic affected primary care practices?
Real briefly, there's a survey of 670 physicians that found out that they've had experience in a drop of 50% during their office visits. And thank you, Diana, for the slide. This was early on in the pandemic. Now here we are in September. What I'm seeing is the exact opposite. There's a lot of economic and social factors that have been affecting what I see over in primary care. What I'm seeing is that there's a lot of impacts that are going on in terms of economics. You have to realize from the patient's perspective, a lot of them that I see, the older patients, they are elderly, they depend on metro and the muni system to commute to work. And there's a perseverance in the Chinese community that the children are stepping in, taking them to their doctor's appointments. And when that doesn't happen, we're able to do video appointments. I mean, here at Chinese Hospital, I work at one of 4 outpatient clinics, and I'm based in the Sunset District of San Francisco. In the beginning, there was a chaos to normality. And one thing as a primary care physician I want to point out is I'm the first point of contact for medical care. My patients are the eyes and ears of the Chinese American community. And they do report what Dr. Lee talks about. There's isolation. Many patients feel like they were in jail. And many of the patients are elderly. And their social contact with the doctor is part of their well-being in that regular health care of their chronic conditions is part of their well-being, and it gives them peace of mind. For the most part, the doctor appointment is the only social contact they have outside of their family. In terms of economics, amongst my patients, a lot of them have chosen early retirement because of unemployment. And with these changes in unemployment, that has been affecting patients coming in. Patients may not have been coming in early on during the pandemic, but what we're seeing is the opposite. Patients' healthcare is part of their well-being, and a lot of patients are losing their insurance, and because of that, they're coming into the clinics more often with the time left that they have on their insurance. And amongst these patients, there are a subset that are still unwilling to come in, and that's where the video visit has really promoted healthcare. And what we're seeing is this new normal where in outpatient visits, there's going to be a subset that won't come in. There's a subset that we have established patients. They prefer coming in. And then there's a subset that have really accepted this new telemed visits. I mean, just from my observations, as a primary care physicians, a lot of regular health care is being delayed. As what Dr. Ko pointed out, a lot of patients are deferring their colonoscopies and other regular healthcare imaging that can be done at the hospital level. So a lot of primary care patients are deferring elective procedures and elective studies. And for the most part, a lot of referrals to the specialists, the patients just simply don't want to go outside the comfort of their primary care. And then other things I've noticed that just patients coming in, they've been gaining weight. Maybe Dr. Kim can also point out that in my patients, a lot of their A1Cs are increasing, the LDLs are increasing. But one thing that through this whole pandemic of what I've seen is that there's a perseverance in the Asian community coming together as a family unit where the young take care of the elderly. The elderly, as you know, are not so digital savvy in the telemed era. Well, I see our family members stepping in, taking time to use their personal devices, the smartphone as a way of communication with the primary care doctor and the patient. It's just kind of amazing that this coming together of the Asian community at the family level has really kept my patients and me updated in terms of primary care. Okay, and thank you.
Thanks, Dr. Ang, for those inspiring words. I agree that the resilience of seeing how the younger generation interacts with the older generations and Asians has been really inspiring. Dr. Chu, a question came in from the audience about, do you think that highlighting these disparities in COVID amongst Asian Americans will allow us to highlight disparities in Asians in general? And would that be a launching point for a bigger discussion?
I think that was a great question, I think by Fiona in the chat. And I think as Dr. Lee mentioned, Descartes Lee mentioned sort of, is this a point in which in Asian American history we can use and leverage sort of some of the disparities that we're seeing to discuss disparities in Asians that we've been seeing for decades that, no one has really talked about and has been really invisible. And I think that there's been a lot of mention about sort of the dual pandemic or the dual crisis of both the COVID pandemic and racism that I think has really brought to light some of these issues that have really been brushed aside. And I think this is a really important stepping stone and time to talk about some of these issues. And I think it's a great point that I think we can all rally together and use our voices to really talk about some of the issues that have really been pushed aside. Great question.
Thank you. So question for Dr. Fung. As I mentioned, Dr. Fung is assistant professor in the Division of Infectious Diseases at UCSF in Department of Medicine. Dr. Fung, what common pulmonary problems do COVID-19 patients have? And then maybe touch on very quickly what MIC-SC is, that syndrome, that strange syndrome that children get.
Yeah, so I think pulmonary symptoms and pulmonary problems really varies on how extensive the involvement is. It can be as simple as a cough, runny nose, and then if the virus goes into the lower respiratory tract, patients can get pneumonia just with the virus. They're also at risk for getting super infections such as bacterial infections or fungal infections. The cytokine storm or the inflammatory response of patients can develop ARDS, stress syndrome, which is what we see in the ICU. And then in terms of multisystem inflammatory syndrome, I am not a pediatrician, and so I will be first to say that I'm probably not the best to comment on this, but my understanding is that it's a very it's a part of like kind of the cytokine storm spectrum, where children have a hyper-inflammatory response. It has been said to mimic things like Kawasaki's disease, with vasculitis.
Great, thank you. We'll move on to the next question. maybe to Dr. Chang first. There's a question about age and pregnancy and COVID complications in general. So have you noticed or have seen any data around women who who are pregnant at later ages? Do they have more complications with some of the complications that you described, preterm birth, etc.?
Yeah, I think that's really hard to tease out. You know, did they get COVID and therefore they had complication, or is it because of their age that they have complication? Just because, you know, higher age does lead to more complications. So I don't have a specific answer for that.
But it makes theoretical sense, as you said. One question for either Dr. Gordon Fung or to Dr. Eugene Yang. What about strokes in Asians? Have you seen any interaction between, in terms of thromboembolic disease, strokes and these cardiovascular complications that seem to be more pronounced amongst Asians? I'd say anecdotally, I've seen a lot of Asians in our unit with COVID and strokes.
Yeah, there's been an uptick in the number of strokes. It used to be said that with the East Asian population in particular, there was a higher incidence of intracerebral hemorrhage as the cause for the stroke. This has not been seen in the COVID era. So it's just mainly the acute ischemic stroke, either thrombotic or thromboembolic.
Great, thank you. An interesting question about Hong Kong versus the US. I didn't know if anybody in the audience who took care of intensive care unit patients here. Certainly, many of us do. The question is, negative pressure rooms are used widespread in Hong Kong for pretty much all, if not, as many as they can for COVID patients. And the question is, what have you seen with negative pressure rooms in the US? And I can answer it if nobody else has the answer from their experience.
I can just comment on what our policy is at UCSF. Our policy is for patients who are receiving aerosol generating procedures for them to definitely be in negative pressure rooms. And that tends to be a lot of our ICU. And so those are patients who are on like high flow nasal cannula or getting, any nebulized medications.
Great, thank you. One question for the primary care physicians in the group is just about free vaccines, and maybe everyone can talk about that. There's a question about, many Asians are in multi-generational families, and if the vaccine were associated with barriers to come and get them, co-pays, trying to figure out insurance, many people won't get it. Do you have a opinion on free vaccinations in general and about COVID vaccinations once they are here?
Most vaccines, better vaccines, are covered by insurance. As far as free vaccines, I'll definitely look into that. In terms of reception of having a coronavirus vaccine, I think a lot of patients have been seeing rumors and have stopped by the clinic and asking for the coronavirus vaccine. So I don't know if there's a lot of misinformation out there in terms of the Asian community that there are vaccines that are available in the US.
Definitely. And there was some word that as part of Operation Warp Speed that all the COVID vaccines will be free. But again, the proof is in the pudding. I think we'll see what happens. But yes, not only will the vaccines have to be free, you kind of have to go and do outreach because people are not going to come to clinic to ask for vaccine. You kind of have to go and find them. Maybe Dr. Dan Eng, do you have any other thoughts about that? Like, how do patients, how do you give vaccines to Asian patients in the primary care setting?
Well, at least in the UCSF clinic where I work, all our patients have some sort of insurance, whether it's Medi-Cal, Medicare, or private. And a lot of times we tell our patients to just get it from the pharmacy because it's more convenient for them, as we try to minimize the number of patients who come to our clinic, just for safety's sake in terms of distancing and everything else. I'm not sure what the answer is to the patients who do not have insurance. had not seen any announcements from the San Francisco Department of Public Health. I'm hoping that they have something in the works where those without insurance can get vaccinated, hopefully for free, because I think this is an important public health initiative, especially during this pandemic.
Great. I have a question for Dr. Gene Lau, actually, because we haven't heard him talk yet. And Dr. Lau is a famous internal medicine doctor at Kaiser Permanente. I just wanted to know how has Kaiser responded to COVID-19 in general, because so much of Kaiser is that that outpatient visit, and when people had to go shelter in place, they weren't coming in. And how has Kaiser responded to all of that?
Yeah, so I think we, as a healthcare system, pretty much did what every healthcare system do, which is, follow the public health orders. So we went completely, pretty much virtual care starting March 17. And since we've actually have a system in place for both telephone visits and video visits, we were able to pretty seamlessly move to telephone and video visits. But, as Dr. Deng said, the challenge is, of course, taking care of our patients in a new way. Any telephone and video visits can do a lot, but, as physicians, we're trained to put our hands on the patients, and the touch is a pretty important part of therapy. And so, missing that, I think, we do see that there are some delays in sort of providing the optimal care that we would like. So right now we're really just catching up, going to offering patients in-visit appointments, in-office appointments. There is a interesting transition that, which really surprised me, is that many of the elderly Chinese patients, through one way or another, was able to actually get on the video, many through the help with their family. And I got to give a shout out to our medical assistants who often spend a lot of time helping that patient get on the video. So I think we're doing our best to really provide the best care we can. And my guess is that there's going to be a lot of catching up to do. With unknown of what's going to be the twindemic that might be coming through, both the flu and the second wave of coronavirus. My guess is that there'll be a challenge for the next number of months.
One quick follow-up question, Dr. Lau, is, do you think Kaiser is going to change after COVID? Do you think a lot of people are just going to switch to video visits, and what's going to happen?
Well, I think we have actually embarked on a strategy of trying to offer people access to a healthcare system any way they feel comfortable with. And so, if it's email, if it's telephone visits, if it's video visits, if it's office visits, since we're integrated system, since we're salary employees, rather than having to worry about the number of visits and getting paid per visit, we do have the opportunity to kind of look at what the patient needs and wants are. So I think our strategies going forward will be a combination of all of the above, and really try to leave it to the patient's preference to the best way they can access us.
Great, thank you. Another question for Dr. Chang. What kind of precautions are people taking around COVID, specifically in labor and delivery? And I would extend that to any gynecologic procedure.
They're only allowed a specific number of people that are with the mother that's delivering, and usually that is one person. And also, they're wearing face masks. Mm-hmm. Yeah.
But I guess a related question, I think from the ID perspective, we don't typically consider that aerosol generating like we would intubation or bronchoscopy. So I think, one doesn't have to wear additional protection or keep in a negative pressure room, for example.
Thank you so much, Dr. Peter Chin-Hong. You did a great job as a moderator. How lucky we are to have you. I also want to thank all the faculty joining us today, because you definitely did great on, your presentation and answering all the questions and all that. And I hope that the participants today got a lot out of what you were trying to get us to know around your area of expertise. And thank you all for the participants too for joining us. And so we hope that you stay safe and healthy. But before we finish, I really want to give a big thank you to Ms. Alice Wu, and also Dr. Eugene Yang. Dr. Eugene Yang, as you know, is from the University of Washington. So he's from above us in the north, hundreds of miles away, and he's helping us to find a donor to sponsor for the roundtable today. So we thank you very much. Ms. Wu is an international humanitarian who is passionate about contributing to the arts, medicine, and humanities. So we are very happy that she is able to contribute to our roundtable today. Thank you all for joining us. Hope that if we have a chance that we'll do more roundtables like this. Thanks a lot. Goodbye now.
Bye.
To all. Thank you.
Thank you.
Thank you so much for having us. Thank you.